cancer or stomach cancer is a cancer that arises from the lining of the stomach. It's actually relatively rare in Ontario and North America, but very common worldwide. Despite the fact that it's not very common, it is a common cause of cancer-related deaths. So it is important for us to look at that in Ontario because of the impact on patients, and it's also a very costly cancer to treat. When you look at gastric cancer in Ontario, about half of the patients present with what we call stage 4 disease, or gastric cancer or stomach cancer that's spread outside the stomach. In those cases, we can't cure the cancer, but we can offer a lot of support for the patients in terms of quality and quantity of life. So something like chemotherapy may extend both their quality and quantity of life, improving their survival. But unfortunately, we can't cure those patients of the cancer. So this is actually a very special study within ICES. So most of the time we take ICES data and look at CIHI data, Ontario Cancer Registry data, and physician billings. For this study, we actually went out to every hospital within the province and abstracted the pathology report and looked at the operative notes of the patients to figure out why they went to surgery and some of the surgical considerations that were taken into account for the patients. So we took a primary chart review for over 3,000 patients, and from this we looked at 1,400 that had metastatic disease. So that would be metastatic disease on their radiology report or on their pathology report. So the key findings are that there are variations across the lens in what's provided. And this is important both for patient outcomes, but it's also important for how care is provided across the province. When we look at these 1,400 patients, we see 41,000 hospital days. We see nearly 5,000 endoscopies, 14,000 CAT scans. This is a very resource-intense cancer, and we need to look at how care is provided for these patients because there may be ways to decrease the impact on resource utilization and save money for the province while providing good quality care for the patients. When we look at chemotherapy, the percentage of patients who receive chemotherapy ranges from 1/4 in one LEN to 50% of patients in another LEN. And when we look at high-tech procedures like a stent to unblock an obstruction, it ranges from less than 2% in one LEN to 12% in a different LEN. So this is probably not based upon variation in the type of cancer symptoms the patients are having, but maybe the resources available within the different LENs, or perhaps the physician attitudes. And that's one of the things we'd like to study next, is why we have these significant differences. This study does have some limitations, and one of those limitations is we can't really capture what's important to the patients or the preferences of the providers. And so there's a lot of things that go into the decision to go to surgery or to start chemo. The patient's wishes, their level of quality of life, their fear of chemo, their problems with pain. And one of the things we're doing right now is looking at the symptoms patients are having. What our group is working on right now is integrating some symptom data from Cancer Care Ontario, and that's the ESAS score, the Edmonton Symptom Assessment Score. And what that does is every time a patient comes to a cancer center, they log in and say how much nausea they're having, what's their pain level, what's their overall well-being. And we're going to use that data, link it to our cancer patient cohorts, and see how well we're doing as a province to control pain and other symptoms. When we look at gastric cancer, it's actually one of the highest cost cancers to treat because of the complexity of the cancer and because most patients will undergo 2 or 3 different types of therapies like surgery and chemo, or surgery and chemo and radiation. So it becomes a very expensive cancer to treat, both for cure and for palliation. The next thing our group is looking at is exactly how much do each of these components cost and what's the variation of the cost amongst the LENs. And we'd like to do that so we can figure out maybe what's the optimal treatment path for the average patient and how far off the optimal treatment path some patients are. Stomach cancer is not something that's been well studied in Ontario. So there are a few groups that have studied smaller hospital-based outcomes, but really no groups are studying how it's affecting the province. And I think what's really important is to measure how patients are doing across the province under a variety of settings. So we've looked at patients who are trying to cure, but we're also looking at patients who are trying to support through stage 4 disease. And I think the important part of this work is establishing the background rates of treatment and therapies, so that as we have guidelines that come out, we can measure against that and see how we improve over time.